Hello my dear students, I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. This lecture is a part of my central nervous system's lecture series. In lecture 1 in spinal cord, we did the exterior of spinal cord. In lecture 2, we did a section of spinal cord, understanding the internal organization of spinal cord. Lecture 3 and 4 were about ascending tracts, and now lecture 5 and 6 is about descending tracts and spinal cord lesions. Okay, so let's dive in for the topic for today, which is pyramidal tracts, spinal cord 5, which is a descending tract. So let's ask ourselves, what are descending tracts? Descending tracts carry motor impulses from higher centers to lower centers in the spinal cord. Meaning what? Your cortex takes a decision, it is carried down by descending tract and it is converted into action by your spinal nerve or your cranial nerve. That tract which is carrying the information from your cortex to your cranial nerve or to your spinal nerve is called as a descending tract. Such descending tracts can be pyramidal and extrapyramidal. We call them pyramidal when they are consciously carried out actions. I am consciously picking up this mouse, pyramidal tract. Okay. But sometimes I do something to balance my body. I'm not doing this consciously, it's automatically happening. Extrapyramidal tracts. Today we are going to concentrate on the pyramidal system. Right. So pyramidal system is a motor system dealing with voluntary, discrete, skilled actions. It's not big actions, fine actions. Okay. Which are new. All these fine actions are learnt by us over a period of time during our evolution. We were not able to do fine handwriting and fine work earlier. We have evolved into this creature who is able to do all this. So this system is the evolution wise, it's a new system, a newer set of tracts in our body. Whereas there is an older system where the body is automatically balanced, where a lot of motor activities are taking place automatically. This is called as an extrapyramidal system. It is not conscious. So your body actions or motor activity of your body can be divided into conscious and unconscious. Conscious pyramidal tract, unconscious extrapyramidal system. Today we are talking about pyramidal tracts. Pyramidal tracts can order my cranial nerves, corticonuclear tracts. They can order my spinal nerves, corticospinal tracts. So, the pyramidal tracts consists of set of tracts which order my cranial nerves and therefore are corticonuclear, which order my spinal cord or spinal nerves, which are referred to as corticospinal. So, it consists of two types of tracts. They all take origin from the cerebral cortex. They all pass to either brainstem or spinal cord. In brainstem, they reach the cranial nerves. In spinal cord, they reach the spinal nerves. Common sense, absolute basics. Right. So now we are essentially talking about corticonuclear and corticospinal tracts combined together as pyramidal tracts. So let's begin with origin. Kahan se hota hai? Where do they origin? It's a tract. It's going to have a neuron and it's going to have an axon, right? So where is the neuron of this tract? The neuron of this tract lies in the cerebral cortex and is called as an upper motor neuron. This is very important, students. Please repeat it once. The neuron of this tract lies in the cerebral cortex and is called as the upper motor neuron. This is the pyramidal cell. Can you see how its dendrites is spreading out in the cortex, but its axon is descending down. It is this axon which is going to descend down and form my pyramidal tract. So what do I know? I know that the cells in my cerebral cortex are giving rise to axons which form my pyramidal tract. Which lamina of cortex? Mostly lamina 5. Okay. So which part of my cortex do they take origin from? Itna bada to cortex hai. Kahan se aayega? Okay. So you have to think that most of these 1/3 of them come from primary motor area 4. 1/3 come from premotor area, area 6. And rest 1/3 and come from area 312 or occipital or temporal gyrus. So what does this mean? Do you understand what I am saying? I can understand that the neuron is coming from area 4, which is motor, from area 6, which is motor. But what are fibers doing coming from sensory cortex? Sensory is supposed to receive, right? So what is it doing, giving rise to tracts which are part of corticospinal tract? Think about it. I'm going to explain this to you, but it's so beautiful. I hope you enjoyed. So from my motor area 6, motor area 4, and also from my sensory cortex, tracts have started to descend down. Okay, where are they going? They're going to brainstem and spinal cord. So how many fibers are these? There are about 1 million fibers. Okay, 90% of them are thin fibers, 1 to 4 micrometer in diameter. But 3 to 5% are really big, 20 to 22 micrometers in diameter. Some of these cells of origin are called cells of Betz. You might have been asked about it. I really don't have time to discuss this. Maybe when I do motor cortex, I'll discuss cells of Betz with you. So all these fibers, thin as well as thick, begin to descend down, right? Are they myelinated? No. In the beginning, when they are formed, they are not myelinated. Over a period of time, they will develop myelination. Maybe by 2 years, many are myelinated. So what happens is that, see, look at a child, the motor activities of the child. By the time the child is 2, the tracts which are controlling micturition in the child have got myelinated. So the child soon develops ability to control micturition. So this is related to development of myelination of these tracts. So I have a question. How is my body represented in the cortex? If it is controlling my lower limb, then is there a lower limb in my brain which says, okay, which corresponds to my lower limb? Actually, body is represented in your cortex. Okay, take a look. Can you see how big my face is or anybody's face is? See the size of the hand. See the size of the lower limb. But you will feel, ma'am, but this is now not how we human beings are. We don't have such a big face. This representation is dependent upon the skill of motor activity in an area. My hand, which is extremely skilled, is having a huge representation in my cortex. Whereas my lower limb, which is not that skilled, is having a tiny representation. So we do have a representation in our cortex which is completely dependent upon skill of motor activity. Got it? So this is called as motor homunculus. What is it called? Motor homunculus. Please say it once. Motor homunculus. This is body representation in the cortex, dependent upon the skill of motor activity involved, not upon the size of the body part. So remember, area 6 is the part that will decide the series of muscle contractions required for an action, whereas area 4 will carry out that action. Some basic. Right. So now pause, think. My cortex is now ready. I know that I have my own body representation in my cortex. I know I have neurons sitting ready to give rise to axons to produce my corticospinal or corticonuclear tract. As these tracts begin to descend, okay, do they directly go to my cranial nerve or to the spinal nerve to order an action? No. When they are descending, they are giving rise to collaterals. Think, when you leave for a party, say at 10 in the night, while leaving you will tell your mother, Mom, I'm going, I'll be back by 1. Why do you tell her? Maybe you tell your dad also, he's sitting reading the paper in the hall. You will say, Baba, I'll come back, I'm leaving for a party. While leaving, you find your brother sitting outside and you will say, bro, I'm coming back, I'm leaving for a party. Why do you do that? Because all these are representing centers which are going to give you some response which will keep you safe. Mom will say, okay, but be careful, drive safely. Your dad will say, Baba, wear a helmet. Your brother will say, oh, leave by 12, 12:30, it gets too crowded there. Whatever it is streamlining your actions, isn't it? That's exactly what the cortex does. While descending down, it gives collaterals to corpus striatum, red nucleus, cerebellum, etc., reticular formation. So, the subcortical centers are informed about any action that the cortex is taking. So, if you're planning to take a jump, cerebellum says, it receives this information that you're planning to jump. So, cerebellum says, okay Baba, if you want, you jump, but don't jump from this height. Go a few steps down and then you jump. So, that way you will manage to maintain your balance. If you jump from that height, you're going to fall. So, this kind of, in Hindi they have a very beautiful word, tippani, advice. This kind of advice is received by corticospinal tract from subcortical centers, and that is why you never fall. You manage to balance your body. That's because subcortical centers are giving cortex advice, and it is implementing this, modifying its action so that the body remains safe. Right. So, look at this beautiful image now. This is the cerebral cortex where we are at this moment in our study. The fibers start to descend down, forming a fan-like structure called corona radiata. Okay. Now, see the corona radiata. Now, as they descend down, from a lot of fibers, they get compressed together to form a tight bundle of fibers called internal capsule. Now, from internal capsule, the fibers descend down and they are going to go further into the brain stem. What is internal capsule? Question. I'm sure you know, but let's quickly revise it. Here you are seeing three nuclear bundles, caudate nucleus, thalamus and lentiform nucleus. So, these are three nuclei in your cerebral cortex or in your brain on both sides, okay? And can you see that there is a gap in between them? L-shaped gap. This L-shaped gap is called internal capsule. And these fibers of corticospinal tract are passing through this gap, okay? They are now passing through a very narrow gap between these two. It's like you're passing between two big mountains, okay? So, the road becomes so narrow as you make your way between the mountains, which is what your corticospinal tract does as it passes between thalamus, caudate nucleus and lentiform nucleus. There is a relevance to this information. I'll tell you why I'm discussing this soon. So, the body in the internal capsule is represented as head, upper limb, trunk, lower limb. I'll just show you this. Head, upper limb, trunk, lower limb. That's how the body is represented. Just think, suppose your internal capsule was damaged here. The head and the upper limb will be paralyzed. If it was damaged here, the trunk and the lower limb will be paralyzed. So, knowing exactly which fibers are passing through internal capsule is important to understand lesions. Right. So, now the fibers have descended down to internal capsule. Here they are very tightly packed. You've understood this. Now, where do they go? Now, they go to brain stem, which as you know is made up of midbrain, pons, medulla, oblongata. So, what happens in midbrain? Here's your crus cerebri where the fibers are present. They are present in such a way that the head, upper limb, trunk, lower limb are situated from medial to lateral like this. Okay. Why am I discussing this? Because suppose the lesion is medial, the head region will show the lesion, not the rest of the body. So, this is called somatotopic representation of body. You must always know this everywhere. So that these fibers now pass through the crus cerebri of midbrain. Now they descend down to the pons. What happens in the pons? As you know, pons consists of transverse fibers. Pons is an area where there are a lot of transverse fibers passing through into the opposite side cerebellum. Pontocerebellar. Please do this once. Cortico-pontocerebellar. Cortico-pontocerebellar. They are going across pons to go to the opposite side cerebellum. But my corticospinal are descending vertically. So, they have to make their way between these horizontal fibers, and that is why your corticospinal tract kind of gets divided into smaller bundles in the pons. Now they descend further. And where should they go? Common sense. Midbrain ho gaya, pons ho gaya. Where should they go now? Obviously, they'll go to the medulla oblongata. Take a look. In the medulla oblongata, they produce an anterior elevation which is called as the pyramid. Okay. The pyramid consists of corticospinal and corticonuclear fibers, and as they pass through the pyramid, they begin to cross over to the opposite side. Please use your hands. This may seem very childish, but it's creating motor memory in your brain. These are the pyramids. From the pyramids, the fibers cross over backwards and descend downwards as the lateral corticospinal tract and others. This crossing of fibers from anterior to posterior across midline is called as the great motor decussation. Take a look. They are incompletely crossing such that 70 to 90% cross to the opposite side as lateral corticospinal tract. 8% descend uncrossed as anterior corticospinal tract, and 2% descend uncrossed as the anterolateral corticospinal tract. Take a look to understand what is going on here. This is the pyramid here of the medulla. The fibers of the pyramid cross to the opposite side, forming the lateral corticospinal tract. This is 75 to 90% fibers. Rest of the fibers, about 8%, descend uncrossed as anterior corticospinal tract, and a few fibers go to the same side lateral column as the anterolateral corticospinal tract. This is how corticospinal tracts now change side. Majority of them change side. They were descending from my left side. At the level of great motor decussation, they have now crossed to the opposite side. Okay. Now imagine, if were I to have an internal capsule lesion on my left side, which side would be paralyzed? Will it be my left side or the right side? It will be my right side, because the fibers have crossed over in the medulla. What is the crossing called? Great motor decussation. Very good. Finally, these fibers now descend in the spinal cord. So now this is a section of the spinal cord. They sit in the spinal cord here in the lateral funiculus, such that the fibers are from medial to lateral, cervical, thoracic, lumbar and sacral. This is their somatotopic representation. Okay. There was some word sensory modulation, fibers coming from sensory part of cerebral cortex, and I had told you I would tell you about it, isn't it? So let's think. There are fibers which are coming from cerebral cortex, sensory part, descending down to the spinal cord. What are they going to do? They are going to do something which is called as sensory modulation. See, you have a lot of information coming into the spinal cord, and the brain is all the time being bombarded with information. Idhar ye hai, udhar ye hai, lot of sand in the ground and so much. Imagine your foot is on the sand. Millions of tiny particles are sending individual information to your cortex. Each particle of sand is saying sand, 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 sand. Is your cortex ready to accept this much? The cortex sends information down from the sensory cortex and tells all these fibers, okay, I have got the message, there is sand. I don't want to know more about it. Unless there is something different, don't send information up to the cortex. There is a bombardment of information. The cortex is finding it difficult to decide what is important and what is irrelevant. You're walking on sand, every time there are going to be a million information about each of those particles of sand. Does the cortex need to know? No. But in that sand, if there is one single shell, the cortex wants to know about that shell. So it modulates the sensory input, suppressing the information coming from individual sand particles, and promotes only the information about that one large shell lying in the sand. Can you imagine that? Imagine you're walking on the sand. Your brain is receiving information that there are millions of sand particles. After a point of time, you no longer receive that information. You get used to it because your brain has modulated the sensory input at the level of spinal cord. But when you step on a large shell, your brain still registers it, because brain says anything different I want to know. I have to protect you. This is sensory modulation. Please think about it. When I think about it, I get amazed at how smart our brain is. Okay? I hope you also find that joy in it. Alright. So, let's now come to the level of spinal cord. From the cerebral cortex, corona radiata, internal capsule, midbrain, pons, medulla, finally spinal cord. What happens? It's lying here. Okay? This is the lateral corticospinal tract where majority of the fibers have come. Okay? As they descend downwards, okay, the size of the tract is obviously going to reduce because more and more body is being provided with fibers. Below the level of L2, the lateral corticospinal tract is right on the surface because posterior spinocerebellar tract on the surface disappears. Some few details you should know. 55% of lateral corticospinal tract provides information or orders to the upper limb. 20% to the thoracic segment and 25% to the lumbosacral segment. It's worth thinking about that our upper limb has got way more intricate functioning compared to the thorax and the lower limb. And it is also receiving more fibers. Isn't it logical? So suppose more fibers were going to your lower limb, imagine what your lower limb could do. Okay, so this is just an add-on information I felt you should know. So what does the lateral corticospinal tract do at every level? Now it has brought in information from the cortex. It is still an upper motor neuron. It's an axon of an upper motor neuron. What does it do now? It reaches here and it goes to lamina 7 where the neuron is lying. It gives the impulse to the neuron. That neuron carries the impulse to lamina 9, from lamina 7 to lamina 9, and sometimes the lateral corticospinal tract may directly stimulate lamina 9 neuron. And finally, the neuron in lamina 9, which is the lower motor neuron, its axon goes out, supplies the muscle and the muscle contracts. Think about it. Once more, the brain has said that there is some movement to be carried out. The neuron there has sent an impulse through the upper motor neuron axon, and that has reached our lateral corticospinal tract here in the spinal cord. It now gives this information to the neuron lying in lamina 7, which then stimulates the lower motor neuron lying in lamina 9. Sometimes the corticospinal tract may directly stimulate the neuron lying in the lamina 9, which is lower motor neuron. Its axon now comes out of the spinal cord through the ventral root, spinal nerve, and finally supplies the muscle, and the muscle contracts. This is how your corticospinal tracts work. Okay? I have drawn those two blue lines. What do you think that is? If you have understood what I have been teaching you, you will be able to tell. Lateral corticospinal tract is now going to the posterior grey horn and doing something there. Posterior grey horn is the sensory part of my cortex. What is the corticospinal tract doing there? It is suppressing. Remember I told you sensory modulation? It's going into the posterior horn and suppressing extra information that is not required by the cortex at all. So it is doing sensory modulation. So we've done this. So are the corticospinal tracts the only way for motor activity in the body? No, obviously not. There is always the extrapyramidal system, which will also be a part of our motor activities in the body. While the corticospinal tract is descending, it is giving collaterals. It's not like मैं अकेला जा रहा हूँ, मैं मेरा जो मुझे करना है करूँगा. It's not like I'm going to go down and do what I want. No. As I go down as the axon of an upper motor neuron, I am going to give collaterals so that the body works in coordination. If I move my arm forward, my left arm has to go backwards. Who is going to tell it to go backwards? Somebody has to do that. And meanwhile maybe my legs are also moving. This coordinated actions are based on these axon collaterals, which will cause the entire body to function as a unit and not as individual hands and legs and whatever. Like we already said, fibers from area 312 will inhibit sensory input. I don't want to talk too much about anterior corticospinal tract, which is present here. Just remember that it is limited to the cervical and upper thoracic region, bringing about movements of upper part of our body. With this, we kind of have finished our pyramidal tract, but there are some concepts which we now want to reinforce. What is upper motor neuron? What is lower motor neuron? Upper motor neuron starts in the motor cortex. Its axon helps to form a tract. It gives information to the cranial nerve nucleus or to the anterior horn nucleus of spinal cord, where lie the lower motor neurons. So, upper motor neuron is lying in your cerebral cortex. It will stimulate either the nucleus of a cranial nerve or the nucleus of a spinal nerve. Lower motor neurons are the nuclei of cranial nerves or the nuclei of a spinal nerve. That means neurons lying in the anterior horn or neurons lying in the nuclei of cranial nerves. This is upper motor neuron, this is lower motor neuron. Take a look at this image, okay? Let's understand what are lesions of UMN, what are lesions of LMN. This is the cerebral cortex, corona radiata, internal capsule, etc. And finally, the tract has reached spinal cord. This as a single neuron. This entire neuron, starting from this body of neuron to the tip of the axon, okay, lower tip of the axon, this is one upper motor neuron. If I cut it anywhere, right from cortex to the lowermost tip, it's an UMN lesion. Anywhere I want to, I can cut it anywhere, on the same side, on the opposite side, anywhere. It will still be an UMN lesion, upper motor neuron lesion. Whereas, starting from the anterior gray horn and going to the muscle is one neuron. This is the body of the neuron, this is the axon. If this is damaged anywhere, it's a LMN lesion, lower motor neuron lesion. This can be a cranial nerve, this can be a spinal nerve. But if the neuron which is directly supplying the muscle, the body of which is lying in brainstem or spinal cord, is damaged, then you call it an LMN lesion or a lower motor neuron lesion. Okay students, let's now do the last part of today's discussion, which is lesions of pyramidal tract. What is an upper motor neuron lesion? What is a lower motor neuron lesion? For that, let us understand once for all what is an upper motor neuron, what is a lower motor neuron. So this is the diagram I want you to concentrate on. If you remember, I told you the upper motor neuron, the body of upper motor neuron lies in the cerebral cortex. Its axon begins to descend down, passing through corona radiata, internal capsule, midbrain, pons, medulla, crossing over to the opposite side, descending downwards into the spinal cord. This entire thing is one single neuron, which we refer to as upper motor neuron. Okay? So, this upper motor neuron, wherever it may be cut, is still referred to as a UMN lesion or an upper motor neuron lesion. It could get damaged in the cerebral cortex, it could get damaged in the medulla. Wherever it is, it's a UMN lesion. Whereas, it will give this impulse to the neuron whose axon supplies the muscle directly. So, that means the neuron that is lying in the anterior gray horn or the neuron that is lying in the midbrain or in the pons or in the medulla, supplying cranial nerves or spinal nerves. Okay? All these neurons are called as lower motor neurons. So, the neuron which is giving rise to a axon which supplies my upper limb muscle is a LMN. The neuron which is lying in the midbrain, which is supplying, which is forming the oculomotor nerve and supplying my eyeball, is an LMN, is a lower motor neuron. the neuron that is giving rise to the glossopharyngeal nerve, which is supplying my stylopharynges, okay, is a lower motor neuron. So, the effector neuron is a lower motor neuron. The neuron carrying orders from the cortex down is an upper motor neuron. So, if that neuron is injured, it's an UMN. If this neuron which is supplying the muscle is injured, it's a LMN lesion. Clear to all of you? There may be a direct connect between UMN and LMN, or there may be interneurons involved in between. So, now let's talk about lesions of pyramidal tract. What happens? Suppose the lesion is in the cerebral cortex. The cerebral cortex is so big. If the lesion is even 1 centimeter, the effect is very small because there is a huge cortex there. So, lesions in cerebral cortex have got small sized effect on the body. But if you go to internal capsule where all the fibers are tightly packed, a tiny lesion results in large size symptoms. A tiny lesion may result in hemiplegia in a patient because all the fibers are so tightly packed together that a tiny half centimeter lesion could see massive repercussions in the patient. Okay. Now let's talk. So that's internal capsule. Suppose the lesion is in the midbrain, in the pons, in the medulla oblongata. Let's see what happens. Suppose the lesion is in this part of midbrain, anterior part of midbrain, where there are corticospinal fibers here, along with fibers of the oculomotor nerve. Now think. Now's the time for me to understand whether you've really understood. These fibers in the midbrain are direct descendants of the upper motor neuron. So, I will see an UMN lesion, okay, for the body. But these fibers are coming directly from the nucleus of oculomotor nerve. They are lower motor neuron. So, I am going to see a mixture of lower motor neuron for the oculomotor nerve, upper motor neuron for the rest of the corticospinal tract. Second question, will this lesion be on the side, will this lesion show symptoms on the side of the lesion or on the opposite side? On the opposite side, because these fibers are going to descend to medulla, cross to the opposite side and supply the opposite side body. So, what do you see? Contralateral UMN lesion, ipsilateral LMN lesion. I know it's a lot, but when you do midbrain, you're going to anyway do this again. Okay, it's actually maths. If you draw this, you will find yourself answering like this. Okay, take it down to Pons. In Pons, I've got two major cranial nerve nuclei. One is my abducent nerve, other is my facial nerve. Sometimes the abducent is damaged along with the lesion of corticospinal tract, in which case you call it Raymond syndrome. Sometimes the facial is damaged. It's called Millard-Gubler syndrome. Again, because the UMN neuron is damaged, the lesion will be an upper motor neuron lesion for the body. But because the lesion is to the cranial nerve itself, which means the lower motor neuron itself, it will be a mixture of UMN and LMN type of lesion. Think about it. This is medulla oblongata. This is called as the Digerine syndrome, okay, where the pyramid is gone, the medial lemniscus is gone, along with the damage to the hypoglossal nerve. So, again, this is above the level of crossing. So, you will see contralateral upper motor neuron lesion. Will I see any loss of touch, fine touch, pressure? Of course, because I have my medial lemniscus damaged, right? Which obviously I hope not, but if it happens, this is what happens. And of course, the hypoglossal nerve is damaged. So, that's a lower motor neuron lesion. This is how we understand lesions of pyramidal tract. Finally, we are taking this down to the level of spinal cord. A lesion of spinal cord, how will you handle that? Okay. So, this is an order coming from the cortex. So, it's a upper motor neuron order running along the upper motor neuron. It is handing the information to the neuron lying in the anterior grey horn, which is the lower motor neuron, which is then supplying the muscle. We know this much. Suppose this is your lesion, okay. So your upper motor neuron is gone and your lower motor neuron at that level is gone. So what is the lesion you see? Below the level of this spinal cord, you're going to see an upper motor neuron lesion because the tract is gone. At the level of the spinal cord, where the lesion is, you're going to see a lower motor neuron lesion. Think about it. Okay. What is also lost? Will I see any fine touch losses? Of course. Fasciculus gracilis cuneatus is gone. So loss of fine touch, vibration sense. What about pain temperature? Yes, I will see pain temperature loss because my lateral corticospinal tract is lost. But this is carrying sensations from the opposite side. So, while I see lesions on one side, I see pain temperature loss on the opposite side. Isn't it amazing? Think about it. Isn't it amazing what we are seeing? And if you put together all the information that your patient is giving, you can tell the level of the lesion. Okay, below the level of the damage, on the opposite side, you would lose pain temperature. On the same side, you would lose motor activity in the form of an upper motor neuron lesion. You would lose fine touch pressure in the form of lesion of the fasciculus cuneatus and fasciculus gracilis. Okay, this is mathematics, but for that you have to know all the tracks well. Okay. So this is what is hemisection of spinal cord all about. So with this I have completed discussion on pyramidal tracts. The next lecture is going to be extrapyramidal tracts and a special discussion about spinal cord lesions. I have already completed lecture on which is about ascending tracts. Also I have taken a lecture on spinal cord external features, spinal cord internal organization. I strongly suggest that you watch all these lectures in a series. What is spinal cord all about? What is its internal organization? What are the ascending tracts? What are the descending tracts? And what are the lesions of spinal cord? Know your spinal cord to know your CNS, my dear students. If you have to understand central nervous system, you have to know this beautiful part of the CNS, the spinal cord. Students, if you like this lecture, do like and subscribe to my channel. Share your thoughts in the form of comments. I long to know what you're thinking when you see my videos. Let me know if you have any doubts. I'll be more than happy to make videos which will help you to understand your subject better. I loved taking this class. I hope you enjoyed it too. Bye.